Ewing sarcoma. Why is Ewing sarcoma called so? The sarcoma that we currently call Ewing sarcoma was first described in detail by pathologist James Ewing in 1921. Given their appearance, he thought that the tumors may have originated from the endothelium, and he named them diffuse endotheliomas of bone. It is impressive that with the exception of their relationship to endothelium, nearly all of the characteristics he described remain pathognomonic for Ewing sarcoma to this day. Codman created the first sarcoma registry, and within its description he refers to the sarcoma as described by Ewing as a Ewing sarcoma. Codman would be probably best known for radiographic finding of a Codman's triangle. Does Ewing's have its own family? The molecular study showed similar genetic profiles and translocations for 3 tumors: primitive neuroectodermal tumor, PNET, Askins tumor, and extraskeletal Ewing sarcoma. They were subsequently felt to be related, as opposed to distinct entities. As a result, currently they are all considered to be a part of the Ewing sarcoma family of tumors. What is special about histology and molecular pathology of Ewing sarcoma? Ewing sarcoma carries a balanced translocation. In 85 to 95% of all Ewing sarcoma patients, this rearrangement fuses the Ewing sarcoma breakpoint region 1 gene, EWSR1, on chromosome 22 to the friend of leukemia virus integration site 1 gene, FLI1, on chromosome 11. The resulting fusion product functions as an oncoprotein that is both necessary and presumably sufficient for tumorigenesis. Histologically, Ewing sarcoma appears as sheets of homogeneous densely packed small round blue cells. They have a high nuclear to cytoplasm ratio. Unfortunately, they appear very histologically similar to other blue cell tumors, so the differential includes other diagnoses such as lymphoma, leukemia, small cell carcinoma, rhabdomyosarcoma, neuroblastoma, and others. One of the main ways to distinguish Ewing sarcoma from these other diagnoses is through the use of immunohistochemistry. Most Ewing cells stain strongly for CD99, while CD99 staining is very sensitive for Ewing sarcoma. It is not specific, as other small blue cell tumors may show some positivity. Also, this is why cytogenetic and molecular findings are typically used to confirm the diagnosis. What is the etiology of Ewing sarcoma? The etiology of Ewing sarcoma remains unknown, despite most cases being associated with reproducible genetic abnormalities such as translocations. Most seem to be sporadic in nature, as no hereditary link has been found. Similarly, an association with environmental factors has yet to be demonstrated. What are the clinical presentations of Ewing sarcoma? As with other primary bone sarcomas, pain is the most common initial symptom of patients with Ewing sarcoma of bone. As the tumor destroys bone, patients may notice a deep, dull, aching pain in the involved region or extremity, although some may notice the pain to be more severe at night. This is certainly not a universal feature, with only about 20% noting it in one study. Unfortunately, many patients who initially present with pain are initially misdiagnosed as having more common benign conditions such as strains or tendinitis. Systemic symptoms tend to be more commonplace in Ewing sarcoma compared to osteosarcoma. It is not uncommon for patients to present with fevers or weight loss, which in the presence of bone pain may mislead the physician into misdiagnosing the cause as osteomyelitis. Laboratory findings can promote this, as many Ewing's patients will have mildly elevated inflammatory markers such as erythrocyte sedimentation rate, C-reactive protein, and other cytokines. It is important to note that in general these lab values, while elevated, are lower than those in patients with true osteomyelitis. Other abnormal laboratory findings include the presence of anemia as well as elevated markers of bone turnover such as lactate dehydrogenase and alkaline phosphatase. How do we diagnose Ewing sarcoma? Biopsy is main way to diagnose Ewing sarcoma. It is preferred over FNACs to evaluate histologic subtype and add suitable molecular genetic analyses, which in turn guide the decision-making for multimodality therapy. The workup of suspected sarcoma requires more material than can be obtained from a fine needle aspiration. How do we stage Ewing sarcoma? MRI is the most sensitive imaging technique for evaluating Ewing sarcoma, and can be especially helpful in cases where the radiographs are indeterminate. It is important to include the entire involved bone in the MRI study to evaluate for skip metastases, which are non-contiguous tumors present within the same bone, and may be present in 10 to 20% of patients. For pulmonary disease, CT scan of the chest is done to evaluate for osseous metastases, either a PET scan or bone scan. Ewing sarcoma by nature is a high-grade tumor and is considered to have mets at time of diagnosis, so every effort is made to detect micromets if imaging is negative. Traditionally, this has been achieved by performing either a unilateral or bilateral bone marrow biopsy or aspiration looking for malignant cells. There is little evidence to suggest the utility of this, and its use is somewhat institution-dependent. What is the treatment of Ewing sarcoma? This is a disease that by definition has micrometastatic disease at diagnosis, so treatment starts with treating metastatic disease by systemic chemotherapy, and then local part treatment is done. Neoadjuvant treatment is typically given for at least 12 weeks. Main active drug in Ewing sarcoma is doxorubicin. One commonly used regimen is ifosfamide with etoposide alternating with VDC, vincristine, doxorubicin and cyclophosphamide, every 21 days. This regimen is common followed in North America and based on classical trial North American intergroup trial INT0091. High-dose chemotherapy is also given with bone marrow support by colony-stimulating factors. In local therapy, if R0 resection is possible, then surgery of local part is done, else radiation is given to local area. In case patient presents with metastatic disease at onset, then chemotherapy is given as primary treatment. Local treatment can be given for palliation of symptoms. Concepts of Oncology, a new channel for learning about various cancers. New videos every week. Subscribe now.